they try to maintain the sufficient output, or they try to maintain the blood pressure, they try to maintain the renal output. And this is also for about some few days to few weeks, for few years, I can say, and then followed by any initiating factor, or by some sort of some other etiology, they finally turn up into decompensated heart failure, thereby the patient up into severe short of breath. Here you are going to see the patient which has got decreased in the ejection fraction. There is a decrease in the exercise tolerance. There is a shortness of breath. The patient has typical orthopnea, PND, and all these symptoms of heart failure. Basically, they are now going to show a lot. Now, even though if this is now this phase usually progresses to a phase called as a refractory heart failure, where you are no means or no none of our medical therapy till now except the cardiac transplantation will be of beneficial. So this phase is called as a refractory heart failure. So here we need to understand that we must try to like understand into which part of heart failure thus they are going to fit. There are the list is very long of all those drugs, right from beta blocker, AC inhibitors, ARBs, till the diuretics and all. But we must try to understand that what are all the drugs, where we need to put them. So before adding on these drugs and endless drugs, we need to understand that to which group they are in now, right? Now, this is something I've just tried to make you understand that there is an staging A, B, C, and D. In the same way, what we have something called as asymptomatic, followed by compensated, decompensated, and then the refractory. It is more or less the same. So I just request the audience just to go through on to the therapy, right? So here we understand that in the goals we have gotten in the case of a stage 1, we don't find the patients coming up with an heart failure, or we don't diagnose the patient at this point as a heart failure, but still they are in stage 1 heart failure, right? So our main therapy over here will be like AC inhibitors or ARBs in order to decrease the hypertension. If there is an atherosclerotic, we need to give up statins. If there is a case of a diabetes, we need to give a appropriate diabetic therapy, right? Now just come up to the stage B. These patients have now got some structural heart disease, as I said earlier, but maybe with or without the signs or symptoms of heart failure, right? So once again, just going to these goals, we need to prevent the HF symptoms, that is the like shortness of breath, orthopnea, and PND. Drugs can be like it can be started like ACE or ARB in the case of selected patients. If the patient has got previous MI, and if the patient has got a decrease in a LV function, or there is significant LV dysfunction that causes a lot of shortness of breath or exercise intolerance, then these patients, or even in the history, if it is there that these patients have got a significant or a life-threatening VT episode, ventricular tachycardia or ventricular fibrillation episode, then these patients should be good or something called an ideal candidate for an ICD. If at all there's a previous MI, we may need to revascularize it. Now coming to the stage C, one should be very clear over here that in stage C it is not just the patients being worsening from stage B to stage C. Here we have got, as I said earlier, that suppose if the patient is in hypertensive heart disease, he fits in to the category of heart failure with reserved or with this case of preserved ejection fraction. This is HPEF. Here we need to monitor their quality of life, their additional drugs, or their treatment like hypertension, or if at all they are having like this one underlying factors like CAD or ischemic heart disease, they may be revascularized further. But for the patients who have already got reduced ejection fraction, yes, these patients are better being diagnosed earlier if possible. If not, then CRD, this one, CRT and ICD insertion, that is the resynchronization therapy as well as implantable defibrillators will be the better option. And stage D, These are the group of patients where they doesn't respond to any of the drugs, and they are at the same time they are the ideal candidates for cardiac transplantation. Now coming over here with this decompensated heart failure classification, as I've been talking you about, if you're talking about something in the form of this, our clinical scenario, we have got like wet, dry, right? So if you're going to see a patient who is wet, make sure that it is a high volume overload, and in either the cases, it is going to be a decompensated heart failure. Now coming to the answers. So for our thing, we have got like furosemide and AC inhibitor will relieve the symptoms slowly. So not sufficient to restore a compensated cardiac status. Most effective drug for restoring compensation is digoxin, right? And its mechanism of action is like increase in the cardiac contractility that I'll be showing in the next slides. Starting dose like 0.25 mg per day, then the peak effect occurs after like 1 week, and we can adjust the dose, right? So this is a short view of our digoxin. So the main target today is basically digoxin. So my question was pointed toward the digoxin. So now what
So
does
I
this
think Dr. Aisha Ansari gave the correct answer, doctor. A very good congratulations to you, Dr. Aisha.
yeah. So we have got the digitalis, right? So we are going to have, let us suppose this is what the normal it was. With this ATPase, the sodium goes out of the cardiac and comes in with the potassium. Then with excess of potassium inside, it is being exchanged with the calcium out and the sodium in, right? So basically this is a dying heart, or it is a dying cell. So what does we do over here? What does this digitalis do over here is that it is going to stop this action of ATPase. As a result, instead of more of potassium, we are going to have more of sodium. So when there is a more of sodium, we doesn't require a lot of sodium inside, we require a lot of calcium. So now this first action will be a lot of calcium will be there inside, and opening of the calcium channels, so we can have the influx of the calcium within the myocardium. This is the second action, and the third action is something like sarcoplasmic reticulum. We have got a lot of calcium content. It's coming out and then acting onto its troponin, acting and myosin by this way. So thereby, once again, the force of contractility here increases, right? So now, when we're going for the second part of the question, it was like regarding this ACE inhibitor. What does ACE inhibitor do over here? Yes, we may need to increase the dose. We may need to increase the dose of ACE inhibitors, like 5 mg per day at 1 to 2 weeks of interval, till either hypotension should develop or there should be the side effect appear. If not, if the patient is lucky enough, we can go till maximum dosage 40 mg per day. Make sure that whenever we are giving an AC inhibitor, for this one, first drug dose or the first dose hypotension is most common with AC inhibitors. So we usually have a practice of giving AC inhibitors in hospitalization. So at least first dose hypotension is more common with this. So we do recommend hospitalization, or if possible, a close monitoring of the blood pressure. Then, as I said you earlier, for maximum prognostic benefit, AC inhibitors should be used for the highest permissible dosage. It should not be stopped unless if there is a fall in the blood pressure or if there is some another CHF worsening situations, right? And the third part was, can beta blocker be added over here? Well, uh, I can say it is a question it is a question for a debatable question, but still, if the patient is having shortness of breath, or if the patient is in a state of a decompensated, make sure that beta blockers cannot be added anymore. But what if a patient is having shortness of breath in the case of a long standing heart failures? Can we add? If the patient withstands beta blocker, if the patient can tolerate that shortness, minimum shortness of breath. See, whenever we grade a patient for having heart failure, these patients usually have shortness of breath. It's a very rare case, like as I discussed earlier, in the stage A, patients usually doesn't have shortness of breath. But Adding beta blocker for the stage A patients and stage B patients have more better outcomes, as many trials stated that. But in the case of a decompensated and in the fourth stage of heart failure, beta blocker is contraindicated. They are no more of use. So what if the patient is having a heart rate towards the lesser side, let us say about 65 or 70? Can we add? Yes, we have got a cardioselective beta blocker, and the trials which shows more to it are towards the carvedilol and bisprolol. These two are the drugs which are more towards the treatment for heart failure if you are talking about beta blockers. Now, the second question. I think I should give some time over here.
Yeah. So, what is your question now, Doctor? Okay. So, this is a completion of the first case.
So we have got over here a businessman, right? Fine. So like there is increase in the difficulty to put her shoes because of ankle edema and uncomfortable on one pillow due to cough while recumbents. She denies chest discomfort and palpitations. She was on medications that includes etinolol and hydrochlorothiazide, that is a diuretic. Now she's overweight, the heart rate around 70 per minute, respiratory is okay, BP is bit elevated, JVP is elevated, and the chest is notable for bibasilar arrays, right? So here we have got a 68-year-old woman with hypertension, right? Let us see. While like examining her CVS was like S1 was normal, physiological S2 was there, S4 was having with a gallop and with no audible murmur. Extremities show pitting edema up to mid-calf bilaterally. ECG reveals sinus rhythm with LVH criteria, and X-ray shows normal cardiac shillouts with bilateral perfusion with mild interstitial pulmonary edema, and it confirms LVH, and EF is around 65%. Now, which of the following agent has been shown to improve the survival in this condition? I think this question will help you in gaining more confidence in heart failure.
Correct. So again, to repeat what Dr. Ansari said, which were these agents, basically digoxin, verapamil, or dopamine, do you think will improve the survival in the condition that you just described? Okay, so we have a unanimous decision here. Everyone is answering furosemide.
Okay, diuretics. Let me tell you over here, basically none of the drug will be, see already there is one diuretic what we have already given.
Yeah. So again, let me repeat, he's asking which of the following agents. So either you can select digoxin, verapamil, or dopamine. Am I correct, Dr. Ansari?
Yeah, or you can select like none of the above also.
Yeah, you can have a none of the above, but if you could choose one of these, that is what I'm asking people to do. Either you can use digoxin, verapamil, dopamine, or none of the above. Can you please type in your answer in the chat? Okay. Again, the decision seems to be quite unanimous, Doctor. We have, okay.
Digoxin also.
Yeah, let's give you all a minute to think over it, and please answer. Let's give them a minute to think.
One hint from my side that ejection fraction is normal, 65%.
Okay. So, like Dr. Ansari has said, consider the fact that ejection fraction is normal. All right. So, doctor, we have most of them saying verapamil. We have Dr. Savita, Dr. Gulzar, and Dr. Masrat Jan who say digoxin. And we have an interesting answer from Dr. Parvati, who says he's already having left ventricular failure, heart failure, and therefore it's irreversible. So we have maximum we have the answer is verapamil, while we have around 4 doctors who you go for digoxin. So I think if you could tell what the correct answer is.
Yeah. Now I'll just tell you one thing. We have got lost lot of drugs, right? We have got an endless, like all the AC inhibitors, ARB. Now just let me put you one slide over here, which will tell you that make sure. Just before going to the slide, I will just request everyone. There is a physiological S2 split. There is an S4 gallop with no audible murmur over here. And in the echo, it is around 65%. The function is good, right? The except part, like the blood pressure is 170/90. Yes, you can go ahead for decreasing the blood pressure, man. But if it is coming with digoxin, verapamil, dopamine, furosemide, see all these four, like I think you can see over here that the patient is already using atenolol and hydrochlorothiazide. There is already a diuretic which has been over here, right? Apart from the beta blocker. So this question, clearly reflects that because there is a use of beta blocker, it is somewhere near the stage A or stage B, right? But even though there is a good amount of ejection fraction, we are just thinking about to load this patient with lot of drugs. Let us see that whether these drugs do really help or not. Let us see, this is our failing heart. A lot of stack has been kept and poor donkey is not able to pump out, right? Now let us see if we can just reduce the number of sacks of this wagon. This is nothing but the use of diuretics, AC inhibitors, or ARBs, right? And another one we have got for the beta blocker, we are just limiting the speed to not more than 60, right? So this is something regarding the action of a beta blocker. Then we can increase the efficiency by adding on some sort of vasodilators like hydrazine and nitrates. And we have for the digoxin or the inotropes, we have got something like placing a carrot in front of the failing heart. But let me add a point to it. Nobody has taken care for the donkey. That is the failing heart. Nobody has done for that. They have just trying to, make the donkey run smoothly onto it. So basically all these drugs, what we are on, they does nothing better for the failing heart. There is no therapy which is going to improve or which is going to reverse back the failing heart. So if a patient is on hydrochlorothiazide, if the patient is already on a diuretic, if the patient has got a beta blocker added to it, I think it is enough of it, because ejection fraction is good. The patient is more or less right with adding digoxin to it. I don't feel at this point it should be a better option. Well, digoxin can be added, no issues regarding that, can be added to it, because it is a bit sort of controversial question. So I just want you to understand the basic mechanism of actions clearly. That is why that special type of question have been framed out. So basing or keeping this in mind, none of the drugs are going to reverse if a heart failure starts. They are just going to improve symptomatically. There is only a symptomatic improvement. There can be a decrease in shortness of breath. There can be like decrease in exertion on dyspnea. There can be an improvement in the exercise tolerance. There can be like asymptomatic or a full night sleep or a happy sleeping nights can be there. But once the failing heart starts, you cannot revert it back. Or if it is about to start, we can just remodel it back by giving AC inhibitors or by beta blockers or by decreasing them. So here I'm not going to write the answer. The answer will be something like, yeah, you can go ahead. Sorry. You can go ahead with either adding upon digoxin to this patient if the patient feels better with it, but make sure that ejection fraction is good, so there is no point of rejection. Well, AC inhibitor, yes, I do recommend AC inhibitor at this point of time. Dopamine, well, it is dopamine has to be given intravenously, and it has to be given when it is in the face of a decompensated heart failure. And furosemide, I don't think it's so there is point of adding hydrochlorothiazide with a furosemide. Well, if somebody wants to replace it, that's a different issue. But okay, at this point of time, AC inhibitor can be added, or if the patient still feels comfortable with increasing the dosage of hydrochlorothiazide or shifting from hydrochlorothiazide to furosemide, we can do that way. But as far as blood pressure to be controlled, yes, that should be the primary point of concern over here. If you are giving an AC inhibitor, or if you are giving ACE inhibitor to here, then I do can recommend this one, using of this ACE inhibitor for the controlling of blood pressure. Fine. So I think none of them has much effect on this lady. Is it clear for everyone? A 52-year-old businessman presents with increased fatigue and shortness of breath. He finds himself comfortable sleeping on 3 pillows. He denies any change in his usual habits. His medications are once again the same, diuretic and atenolol for hypertension for the past 10 years with good control. He smokes 1 pack of cigarettes. He drinks whiskey socially, and he is going to have 1 to 2 cocktails in his lunch. Heart rate is around 104 per minute, respiratory rate 20, blood pressure 130, bibasilar rails over the lower third of lung fields. CVS is fine with a loud S4 and S3. Holosystolic murmur grade 2 by 6 reading to the axilla. ECG once again shows LVH criteria, and chest X-ray shows it confirms the LV enlargement. So what is our diagnosis? I'm much concerned about the diagnosis of this question.
Okay. So Dr. Ansari wants you to concentrate on the diagnosis. The management, he's also thinks is important, but I think he wants you to focus on the diagnosis. So what do you think is the diagnosis for this particular thing? Dr. Ansari, would you like to give a hint for this also?
It's there in the question itself. Something
Okay.
attractive.
Okay. Okay, guys. So I'm giving you around a minute to think about it. The question is on the screen, so you can go through that, and if you could give us what you think is the diagnosis.
And the answer is on the screen.
Oh, that's another hint that he has given. The answer is on the screen. So
Okay. Very good.
yeah,
DCM alcohol related.
yeah. Yeah, we almost have a lot of people going for the DCM diagnosis. Yes, we have some people going for the left ventricular heart failure also. We have aortic insufficiency. We have mitral regurgitation also as here, but I think most of them have gone for dilated cardiomyopathy. Is the right answer, Dr. Ansari?
So this is an alcoholic cardiomyopathy.
Oh, super. Congratulations, everyone. I think most of them have got this right. So that's great. So do you want them to talk a little about the management also, doctor?
Well, the management is absolutely the same as that of our routine this thing, heart failure. But the only thing is we need to stop alcohol. That is the only additional part of it. And one thing in the question, like, heart rate was around 104. So this patient was going in some compensatory and decompensatory imbalance, right? So this heart rate, if would have increased more than 120, I suppose this BP would have fallen once again. And well, in the question, there is no point of echo over here. So this patient would be having echo around, let us say around some not more than 35 to 40%. Right. We have got over here a 65-year-old man reviewed in the outpatient clinic with worsening shortness of breath, which now caused him to stop halfway walking up the stairs. He had an acute coronary syndrome 6 years ago, and he has been taking bisoprolol, ramipril, that is a beta blocker, AC inhibitor, a diuretics, and MRA for a diagnosis of a heart failure from the last year. Attempts to increase the dose has been prevented by hypertension, since we tried to give up more the dose, but this patient has got hypertension, so we couldn't. So echo confirmed severe dysfunction. ECG shows syndrome at 60 beats per minute with a long PR and LBB. So what is our next appropriate step of management?
Okay, so again, guys, if you could answer this question, what is the appropriate step of management? Like he said, it could either be CRT, it could be a CABG, it could be a cardiac transplant, or it could be a pacemaker. So what do you think is the correct answer? I'll give you another 1 minute to kind of go through the case again and give the appropriate answer. Yeah, guys, please answer. We have
We've got
around
the options
5
like
responses.
CBG,
Yeah.
CAT, yeah.
Okay. Okay.
Pacing, okay. Eva bread. Well,
I think, yeah. So we are having a mixed bag here, doctor. I mean, nobody wants to go for the CRT, but yeah, a lot of them are going for the cardiac transplant, the CABG, and the pacemaker. Quite a mixed bag
well,
here.
yeah. So, well, it is an interesting question. One thing that I am very happy that many of us know the basics, that because this patient has, has a background of an acute coronary syndrome. Definitely, everybody tried to remove out that part. Well, it is a good approach. I do really appreciate everybody for that who has answered for CABG. But let me tell you one thing over here. He had an acute coronary syndrome 6 years ago, and what is the status right now? Whether he was treated for that is not mentioned in the question as such. But if such patient literally comes, it is a very good thing that we are going to the history back to the 6 years, and we are just going to evaluate whether any stent was placed or not. Followed by, if there is a patent stent, or if there was a delayed in revascularization, then definitely the heart failure would have developed in spite of having patent arteries. In spite of having patent arteries, or in spite the CABG would have done, this patient would be in heart failure even after that, because the myocytes which die after an infarction is very difficult to retrieve them back, right? So if the patient is still in ongoing ischemia, if there is still an ongoing ischemia, then our answer would have been a CABG, which would have been the right answer. But 6 years, definitely by the time now, there is no point of that myocytes, even though if you do a CABG or if you revascularize by any other methodology, we are not going to come back, or we are not going to retrieve those myocytes which have already been lost. So the other thing, as per now, is the time that we should go with this some of our guidelines. Like we can have CRT if the patient is not willing for something like transplant, or basically if this patient has like in stage 4, yes, or stage D heart failure, yes, we do recommend we do uh, we do recommend for and he's a good candidate for a cardiac transplant. Now, here we can see on our screens that We have got like AC inhibitors, ARNIs, like we have got beta blockers, we have got like these MRAs, mineralocorticoid antagonists, we have got like SGLT2 inhibitors. Now, these four groups of drugs have been involved or has been the first line of treatment of choice in the case of heart failure. This is as per our NICE guidelines. Now, whenever there is a volume overload, we will try to decrease it with diuretics. At the same time, we have got an this one MRAs like spironolactone. They have been shown effective in improving the mortality as well, right? So now recently we have come up with SGLT2, which has also came up with the same thing, like increasing or a benefit in the mortality as well as in the morbidity. These AC inhibitors can be used with ARNIs apart from these sacubitril and all. Well, now in the question we have been talking about at the 60 per minute, the long PR and an LBB. Right. So here we are going to see that the CRT option fits best over here. One thing which was going against the CABG was that he had a coronary syndrome 6 years ago. So there is a no point of revascularization. Now this patient has got a long PR interval and an LBB. Yes, this is the point where we are going to give a CRT. Right. So at this time of, if there is an ongoing ischemic etiology, then we would have revascularizes or we would have gone with an ICD. Unlike over here, we are having like it's a long time, then followed by a long PR interval, and then LBB is existing over there, and an ECG has got a sinus rhythm, and further increasing of these drugs are not permitted. So I think CRT will be a best option at this point of time. If at all we have gotten facility for cardiac transplant, then that's all time better. But CRT can be done easily. What I suppose, between if you are comparing with CRT with a cardiac transplant, or we need to have some time for the cardiac transplant, so till then at least we can go with CRT, right? So this is a briefing about our heart failure, that we have got like four first line of drugs, that is the AC inhibitors or the ARNIs with sacubitril and valsartan, followed by a beta blockers that even with that beta blockers we have got like bisoprolol, the most then followed by the MRAs that like spironolactone. We have got like SGLT2 inhibitors. I think we have gone through these group of drugs in those uh, uh, the diabetes controlling drugs. Even they found out to be better in the heart failures. But all these four, inspired the recommendation for the by the NICE guidelines as the first line of drug, none of them can reverse back the heart failure status or the heart failure cardiac myosin or the failing heart back to its normal. They're the first line of drugs, followed by, if one cannot, then we can go with like tedigoxin, we can go with inotropic supports, but those are all transiently. Apart from it, we can go with CRT or ICD depending upon uh, the impending factors like ischemic in etiology. We have got like atrial fibrillation. We can go with some anticoagulation at the same time, right? So ultimately, these four drugs carry the first line of drugs for the heart failure. I think with this case based, I think I am more directed towards like which group of drugs has been indicated to which case scenario.
Yes, which is exactly what makes this more interesting
More
because
interesting and more case oriented. It is more
correct.
something called as, yeah, exactly.
Okay, so the thing is that we all of us read textbooks, right, doctor?
We have
But
got a lot of knowledge. I think
exactly.
you can
So
see a lot of participants because they were answering well from the question one. So I came to know that they have got a lot of and then I can say enough knowledge for this heart failure management, but they were like they just need a small guidance depending upon these guidelines, and then the scenario based. So I have more focus on them on that part.
do you want to open the for any questions from there and
Yeah,
Dr.
yeah,
Ansari?
yeah, yeah, absolutely.
So I think Dr. Ansari is very kind. If you If you have any questions about any of the cases that we saw right now, please put in the questions in the chat box. We'll be more than happy to answer it. Dr. Mohammed Ibrahim, I see your hand has been up for a long amount of time. Why don't you write your message in the chat? Do any of you have a question? You can put it in the chat. Um, Coming back to this, Dr. Ansari, like you rightly said, I think the application part of it is what allows theory to be, used. And this is a very, I would say, very useful way of getting them to actually use the knowledge that they have obtained from theory into practical. We have Dr. Sachin Kumar Khade, who he's asking, so what do you think is the correct indication of a cardiac transplant? So when would you go for a complete cardiac
transplant? Yes, that is the stage 4, stage D. That is the most, that is the highly advanced. If in the case like if none of the treatment would have been like successful, even if the CRT fails, even if the case the CRT fails, let us say, for example, if a patient is having age around 70-75 years, we don't we don't go with a cardiac transplant because of another lot of comorbids, like. But at the same time, cardiac transplant is a major surgery where you need to have a donor and then all those things. But in the case of a CRT, if suppose if a patient is around 70 years, what I said, if even in this case the patient is around 70 years and this CRT, it is not going to do much into the surgical pattern. A small scar is made and a pocket is made and the lead is directed towards the heart, that's it. So this comes to be a very simple. This is our first point. Second point, the major thing is that even if the ejection fraction is around 30 to 35%, at the age of 70 or 75 years, we don't expect these patients, or we don't expect these patients to do a lot of work in and around the homes. We need to just make them stable at home itself, at their own regular activities, right? Unless until if the patient is around like is young at age, or it's around, I can say, if even 50s or late 50s also, we can have a try for this type of cardiac transplantation. All right, so we can do a cardiac transplant to this group of patients if they want something more than their regular routine work. At the age of 65, 70 years, or in an advancing age, if the patient is in stage C, I do recommend with a CRT, that will be enough for it.
So we have a question on zoonotic transplants. So
Zoonotic transplant is possible with the what about the recent pig? Yeah, even I have gone through that. This pig heart transplant, yes, definitely. But the thing is that we must also think in terms of this immune system. Our body has got a beautiful immune system. Otherwise, anything available, like we can have a cardiac transplant. But if really, if our immune system permits for that, definitely we can have a heart transplant basing on that also. But we should always think about this immune suppressants, long-term immune suppressants, followed by the bacterial endocarditis. Then all these type of things will be into it, and it is and we have seen a lot of patients, even with this zoonotic transplant, they have landed up into the renal failure. This is once again, the sad part of the story, where we are ready to transplant, the animals are ready to give, but our own bodies sometimes may not be favoring us to do with that.
Okay. So what is your comment on right heart failure, and what do you think would be the
this is a topic like which has been with the left heart failure. So more commonly, the right heart failure, we see a patient in the case of pulmonary artery hypertension. So more or less, rather than putting this right heart failure in an approach with the left heart failure, I would like to say that we need to add the specific treatment or the treatment regimens for the PAH also, the pulmonary artery hypertension, because we can classify this PH and then we can add on the treatment with them. And moreover, this right heart failure and the left heart failure, we see a lot of signs in the case of right heart failure. Like you see pedal edema, you see right from increase in the JVP, we see pericardial this one effusion, pedal effusion, ascites, pedal edema. A lot of signs will be there. But in the case of a left heart failure, you have got a lot of symptoms over there, like shortness of breath. You are going to have dyspnea on exertion, AOE, angina on exertion, dyspnea on exertion, platypnea, orthopnea. So more or less the approach remains the same, because we need to give like we need to decrease the overload. As I have said, I think with this over here, we need to decrease the cardiac output, that is the load on it. Like we need to decrease the heart rate. Apart from these medications, we can add on with, if the most common etiological factor of the right heart failure, and the most common is primary artery hypertension. So the treatment of PH, like sildenafil or its substitutes, it can be added on to it.